I want to welcome all viewers to this webinar being run live on CDA Oasis platform. And today we're talking about a topic that's very dear to my heart. When I spent a lot of time sitting in the operator's stool, I dealt a lot with children in practice. And I think one of the most challenging types of case to come in was the 6-7-year-old with major enamel defects on their first permanent molar teeth. And that's the topic that we're discussing today. And I feel very fortunate that we can invite in two real experts on the topic. And one is Dr. Nancy Vertel, who's a pediatric dentist from the Vancouver area. And she's joined by an orthodontist, Dr. Melanie Matson, also from the Vancouver area. And what we're going to do is we're going to have them, one after the other, do a presentation about enamel defects from the perspective of their particular specialty. And we're going to have it nice and conversational. And I'm going to start with Dr. Nancy Vertel. Nancy, why is the topic of enamel defects or defective enamel so important from the perspective of a pediatric dentist?
Hi, John. Thank you for inviting us. So enamel defects seem to be one of those consults that I get often for different reasons. Sometimes pain, sometimes parents are scared they showed up all of a sudden. Sometimes it's a referral of a dentist confused. I've been seeing this child forever, and then all of a sudden we have major enamel and dentin breakdown. The parents are upset. And sometimes it's just pain management during a attempted restoration also in young children. So it's more common than we think. It's more common than some of the literature we read initially. And it seems to be a frequent consult in my practice. And also topic that involves different specialties, general dentists, and all the other specialties as well. So right. It's very timely.
So a nice topic for interdisciplinary discussion, and that's what we're going to do now. And before we go and go through your presentation, could you tell me, as a general dentist, what are the key takeaway pearls that I'm going to get from your presentation?
The main part, this won't be given in a lecture format. This will be given more in a friendly conversation. I'll present my cases. I'll present also what I suspect is a failure. Still, the jury is out on that. And I expect for all of us to learn to identify it early, how to manage it, refer if we need to, and mostly obtain proper informed consent and tell the parents and all the involved what the possible outcomes are with this type of molars.
Nancy, the show is yours.
Okay, excellent. So I have a set of slides. I followed a few more current papers that have been kind of my guide. One of them is a review of the management, the current management, and some of the interdisciplinary approach. And some of them are my own, the pictures are all my own cases of children that have come to my practice. So I'm gonna make this very informal. I want a conversation. Please, any questions, feel free to ask during the PowerPoint, and I'll be happy to answer. So molar incisor hypomineralization is a technical name where these defects are known by, and it was named or branded as in 2001. Now, it's got a lot of other names: cheese molars, hypomineralization, hypomineralized, demineralized, non-fluoride. So you name it, it comes down to the clinical presentation and the histology. As we know, these molars can be quite challenging to manage, depending on many factors: the age of the child, cooperation of the child, restorative needs. What we find in common with most of these cases is these teeth tend to be sensitive. Once they break down, the progression of the dental decay is fast, goes into dentin quite quickly, and pain and involvement of the pulp is also quite rapid. I don't know if you've experienced anesthetizing it, but with different degrees of success, and I'll talk about it later and why is that. And even when we restore, even the best restorative efforts, we tend to have more failures, more marginal breakdown for different reasons. And it is a topic and it's a clinical case that definitely calls for a more multidisciplinary approach. So this is a case that I treated last year, but this is just my best efforts to give you clinical pictures of what my findings were. The one with the stainless steel crowns, this child had been restored previously under general anesthesia, had all his primary dentition restored, comes, changes cities, comes to me for a regular checkup, and then the 6-year-old molar presents this typical whitish, yellowish, brownish appearance. Most dentists don't think much of it. I used not to think much of it until you see the fast breakdown. And then to the right, you see the typical snow-capped white incisal edge as well, with a very fast breakdown. So basically, the literature says to diagnose it as a defect. Initially, when the molars are first erupted, is diagnosed by a defect in the enamel translucency. So instead of seeing all nice and translucent, you see those white patches around. Here we see more advanced cases. Obviously, the molar didn't get properly addressed when it was either identified or treated early, and the breakdown was massive, even though you see the primary dentition is in very good shape. And you can also see this is a different case where you see the breakdown is starting the buccal surface, but the enamel defect extends all over the occlusal surface. And again, the primary dentition is not in bad shape to explain why the 6s will be so bombed out so early. This is just a little slide of our recent outreach trip to Vietnam with a fabulous group.
I see some friends in there.
I'm not an expert in histology, but I'm going to make my best effort of explaining what science or what the researchers think the defect occurs. So there is a million causes that have been related to enamel hypomineralization, but really we don't know. But what we know is histologically, the defect happens early in the formation of the tooth. So when the layers of dentin have been deposited, right? So what happens is when these layers deposit, there's a small voids or small bubbles of protein that get trapped between the layers of dentin. So it's a bubble. So then the enamel deposits on top of the dentin, and it's all good and happy. So the tooth looks completely normal, morphology is normal, but because inside the dentin is not a compact layer of mineralized dentin, we have protein bubbles. That bubble kind of disintegrates or degrades, and then the enamel on top of it collapses.
So it's like a foundation of sand under a house, right?
Correct. So this is like the way this slide that I stole from somewhere in the internet shows me. Is a bubble really inside the enamel. Okay, so there's a difference. I mean, this is purely semantic, but there's a difference between hypoplasia and hypomineralization. Hypoplasia, you will see when the tooth comes in the mouth is already deformed, has voids, has pits, has abnormal formations. Versus hypomineralization, the molar comes in fairly intact, so the shape is completely normal. But then what we see is fast enamel and dentin destruction, that they collapse, that where we talked about the histology. Yeah. This was part of our Vietnam trip. We did a little off-road to Halong Bay. Okay, so when I have these patients referred to me, the question from the parents is always the same. What happened? What did we do wrong? Was it too much fluoride? Was it too little fluoride? Was it the fever? Was it? So parents are trying to find, why.
And is fluoride sort of like suspect number one that comes out of people's
Yeah, a lot of parents think, was it the fluoride, or was it not fluoride, or was that fever, or was it? So the literature tells us is basically everything and nothing, because could be anything from a fever early in childhood, or to an ear infection, to the normal childhood diseases, plus pollution. Premature birth is one that I actually do tend to see a link. It's not that when the child presented defects, they were premature birth, but if they were premature birth, it's most likely that I will find an enamel defect. That's kind of the link that I found in my own practice. But
Right.
there's a ton of other factors that have been referred to by the researchers. There was one that I found quite interesting. It had to be with a dioxin compound that is found in formula, in baby formula. So they did an experiment in rats, and they gave the rats a ton of that, and they found the rats had enamel defects. Now, it's one of those, how much of it will cause it, how much is it really in the milk, but all these factors. And when parents ask me, the answer is still, I don't know. Could be any of these ones, or could be one that we don't know. The ones that are more related to systemic conditions had to be with cleft lip and palate, that for sure. Radiation therapy, that will make sense, and all these other conditions that are listed here. The prevalence is an interesting fact, because it varies hugely depending on the paper that you're reviewing. So the literature used to say about 4% to 25%, and if you read the studies, really depends by country. Huge variation. And I find in my own practices, I practice in Maple Ridge and I practice in South Surrey, I find the prevalence is much, much higher in the Maple Ridge area. So you will see the consultations with orthodontists will be mostly in that area, because that's where I've seen to see it more around that population.
And are there different ethnic groups concentrated in those different areas?
Not really, and might be just one of those things that I just happen to see it more there. But it is interesting how it's highly prevalent in my practice in the Maple Ridge area. So it also affects incisors. Once you see it in incisors, so it will typically affect all the sixes, plus either the upper and lower incisors. And when you see this, it tends to be more severe.
Right.
The preventive management. So we know the problem is not outside. The problem is inside. So a lot of the efforts that we will go through maintaining this enamel sound will be really futile, because the defect is inside. But things have been proposed as placing a sealant, applying more frequent fluoride varnishes, desensitizing agents type like amide paste, anything that could help absorb the proper minerals into that void, and Recaldent and all these other remineralizing agents. In places like Australia, the management actually is aggressive application of fluoride varnishes. They've got a protocol for a number of months, a number of visits, and they in fact give the parent a kit where the parent can brush the fluoride varnish directly on the defect, and they go through all of this so they're able to restore it with a little less sensitivity, because we know there's molars is a challenge for that.
Maybe they're trying to delay the restoration till the time when the kid is better able to undergo extensive restorative work, perhaps.
Correct. Behavior, and also the anesthetizing factor, which could be a challenge.
Right.
So Nancy?
Yes.
When you see this in the incisors as well, will you get the same degree of breakdown of the incisors?
No. Interestingly enough, because incisors don't withstand the same forces of mastications as the occlusal surfaces in molars, so it does not tend to break down as quickly. Plus, tends to be an area, it's a great question, an area that is a lot easier to clean. It's mostly aesthetic concern, but those I have to date, I don't touch them. I leave them as long as they are calcified enough, they're not breaking down, and they seem to be holding up okay.
Mhm.
Hmm.
This is my stuff. So I'm going to present some clinical scenarios here that I've dealt with. And, you know, the jury is out as to what the right answer is. There is not one answer, and this is just one of the approaches, but there's several, depending on so many other factors, depending in age, behavior, finances, crowding, integrity, restorative needs. So it is not to be taken isolated, is more to be seen the child globally. So I have my clinical case number one. It's a healthy 7-year-old, extremely apprehensive, limited cooperation for anything, and requires a lot of prompting with very protective parents. I know those who work with children know what we're talking about. Very challenging to manage, with irregular dental care. Although they live in Canada, they only have irregular dental care when they visit their country back in India. This child has had history of pain in quadrant 3 for on and off. And at this point where they finally come to see me, they've been avoiding to chew on the left side of the mouth, and they're brushing with warm water, you know, when it's getting there. And the medical history is not contributory, so this is a healthy child. So when you see the mouth, very healthy, beautiful teeth, but you go and look at the 6s.
Yeah.
And there you go. So then there is the question, how are we going to manage this child? This child is very unlikely to cooperate just in the regular chair. Parents are both physicians. They don't want any pain. They don't want any discomfort. What are we going to do with this child? And what is the future of this restoration? So you can see how 3, 6, 4, 6 are affected, especially 3, 6, 4, 6 is also, and I believe 2, 6 was mildly affected.
And there's lingual breakdown on the lower left, isn't there?
Correct, yeah.
That's always a real red flag, the lingual breakdown so early, right?
Yeah, and you see the x-rays, not bad. I mean, it was a little bit of a topical eruption of the 2-6, but it negotiated its way in proper occlusion. And this x-rays might not be the best on this screen, but you can see not a huge curious experience, something very minor here in quadrant 1. So it's not necessarily like it's not high concentration of bacteria or poor oral care, because this child has a pretty good dentition.
Mm-hmm.
Isolated defect. So taking the panoramic x-ray, I found some things that might you know, probably some predicted crowded, and here's where I would need Dr. Madsen to intervene. And the panoramic x-ray shows better the extension of how the dentin is now compromised, especially on the tooth.
That's right.
6. Although it didn't look as bad from the clinical picture or even the bite-tween, so this gives us a better view, and there's some issues of crowding. So, Melanie, do you have anything to add there for what I've shown so far?
Well, it's an interesting case because if the molars weren't hypoplastic or requiring intervention, you know, there's still some need for orthodontic treatment. You've got some, you know, relatively significant anterior crowding and the potential for lower left impacted canine. So that one would have to be monitored.
Correct.
And that anterior crowding is going to help to guide what you do with those 6s, perhaps.
Correct. So before going ahead and restoring this child, let's send you for an orthodontic consultation. So the orthodontist, because my role is to identify, restore. This child was already in pain, but we wanted to do the right thing. I knew we had to do something. So we referred to the orthodontist, and I was so hoping the orthodontist would say, go ahead and take them out. But the orthodontist said, no, let's restore them. I need them. And this is why the timing of the consultation is so important. So the orthodontist said, please restore them, temporarily do what you can. Could be a glass ionomer, an SSC, whatever you like. We will make sure the parent understands this will be a temporary fix, and this is where the informed consent comes, because this child will go through a procedure. It will be either under some type of sedation. We will restore these teeth. Will be fees involved in all this, and this is just temporary until the orthodontic or the right timing comes in to extract them. And Dr. Melanie will probably speak to that. I don't know if that will have been your approach or not, but what she said is she needs them because the crowding is in the front, and she needs those sixes to pull everything back at the right timing for extracting them.
Yeah.
Exactly. So where it is right now, if you were to go ahead and take out those sixes, most likely what you would see is the the path of least resistance would be for the sevens to move mesially. And then when time comes to address the anterior crowding, you've got yourself in a bit of a pickle because you've now extracted teeth, so you're good and don't necessarily have the space available for the crowding management.
And especially if those sevens tilt forward and they have to be righted, that's tricky, right? Okay.
Correct. So we discussed both options with parents. We can restore them permanently now, but what we call permanently, we talked about prognosis, further breakdown, sensitivity, possible pulp involvement, because all the challenges of restoring these molars, like I said, it's a microscopic defect, and even though I think I've removed the defect, sometimes it goes in layers and layers that you can't clinically see until restoration fails or until the pain flares up. So this family chose the option to save them temporarily. And we've done composite restorations. For now, they're asymptomatic, and they're seeing the orthodontics waiting for the right moment to do the extractions.
Was that your office there?
Yes.
Cool.
That's in South Surrey. Yes, it's an underwater theme. Now, case number 2 is a healthy 6-year-old. History of throbbing pain in quadrant 2. These parents, the child was in pain. They asked around, and they were referred to my practice, but they were referred by a dentist. Again, irregular dental care, but very cooperative child, super cooperative child, very shy and quiet, but pleasant. So this is what we have. Again, it's not the typical bombed out mouth. It's in pretty good shape. Good oral hygiene, some small restorations. Actually, this is post restoration. But when she came to me, the tooth 2-6 was the one that presented pain, and also the lower molar. So you can see the extension of that decay. So typically when you expect to see this in a child, you expect to see a lot more decay in the primary molars, or a lot more extensive decay. When it's isolated like this, you suspect something happened. Something happened to the structure of the enamel. There was something else, not just a simple decay that just blew up like this. It doesn't match the rest of the dentition. That's a big wake-up call when you're diagnosing this. So this child was in a lot of pain, and you can see almost like pulpal compromise there. So again, I go over the options with parents. We can restore it permanently the best we can and hope for the best. But she had compromised 2-6 and 4-6. So we said we have 2 molars. They're so, they might give us grief later, but they might not. It's a gamble. Do you want it? Or there's the alternative also of an ortho consultation to see if we can basically, get rid of them and just allow a space for healthy teeth to come in later, and then orthodontic treatment for sure. So parents decided to, the orthodontist actually sent for an orthodontic consultation. The orthodontist wanted exactly the same thing. She said, I need the molars. Let's restore them temporarily, and we will do extractions later on, and a space closure as well. So for this molar, and I wanted to say the challenges of restoration. So if this is what I consider a failure to this point, I restored, and there's two schools of thought when restoring the hypomineralized molars. So I'm pretty sure when you've restored them, you start removing the compromised dentin, and it's darker and brownish and all these different colors, and you keep removing and you keep removing and you keep removing, and you're like, where do I stop? So, and then it feels hard. Do I remove that? Do I leave it? Is going to be another void inside it? Am I going to get into the pulp? So all these questions, and there's no answers. There's two ways to do it. Some say leave it. Some others say go until the end. So for this one, I took the approach, leave some of it, but it felt hard inside. But when I took this follow-up x-ray, I find this radiolucency underneath. So I don't know if it's further decay. I don't know if it's recurrent. I don't know if I left too much of the deceased tissue. I'm not sure. The molar is asymptomatic. She never had pain again, and so we're gonna leave it at that as per parent's request, because these molars will be extracted later on anyways.
Can I ask a question here?
Yes.
In both these cases you've shown us so far, we're talking about restoring these teeth for the purposes of ortho later on. Can the orthodontist and the pediatric dentist predict with certainty how long we need to maintain those teeth? Like at this early stage, would you say, well, it's going to be definitely?
No need to answer, I think.
So, from an orthodontic perspective, usually in a case like this, where we would be potentially planning to extract those first molars as a part of the treatment, what we would be looking for from a timing perspective was the eruption of the second molars. So, in most cases, we would be looking at 12 to 13 years old. So, potentially looking for, up to 6 years lifespan out of these.
Oh, okay.
Yeah, thank you for that. Thank you.
Excellent. So, and another thing I wanted to say, this child, excellent behavior, super cooperative. However, I did mild sedation on her because I knew she hadn't had any restorative experience in the past. I did the only restorative work she has. So, cooperative, awesome, a dream of a child to work in her mouth. But every time I touched the tooth, even though she was anesthetized and sedated, I could see her pulse going up. So that was probably part of the reason why I didn't do my best job at cleaning it, because I know she was hurting. So you can see, and she wasn't, reacting, but I could see her pulse getting altered. So that tells you even when you've made your best efforts to make the child at ease, if I hadn't sedated this child, I probably would have lost her in the chair. She would have been quite upset. So that's another consideration, and that would lead to a bunch of referrals actually that I've had. Now what? So that case I presented in a past study club, and there was endodontists and prosthodontists and other people. So there were half of them, why were you extracted? Do a root canal and a crown. So for sure. And there were others, take them out and close it. And there were the prosthodontists, well, let's do a crown. So, and all of that is right. It's just, this is an approach. This is what I present. But all of the other ones were right, and that's the way that others will have managed it. So, but one thing we have to think about is, okay, I retreat, then I do full coverage, and then what? Then the parents are pain, and they're perceiving that you're failing on them, and you are failing on this child because you're doing more intervention. This child is 6. You have to remember, this child is 6. We'll start doing interventions at 6, and they're gonna pay, and it's going to be discomfort, we know. Multiple sedation appointments or general anesthesia or whatever you choose. We might end up with a root canal at what age? And when are we going to do the final restoration? And how much is it going to cost? And if you put all that in perspective and present it to the parents, then maybe all the involved can make the best decision for the child.
Yeah.
And this is my partner, my friend Melanie.
That Melanie there as well.
Yeah. Working hard.
I miss that lifestyle. Anyways, now we have a little older child, 9-year-old. it was a typical case. It was referred by a general dentist because the behavior of the child deteriorated during treatment. So the dentist was treating, it was happy, everything was happy, and the child kept screaming every time he touched the tooth with air or with a high speed. So closed it, sent it to me, and also there were limited finances in addition to that. So this is a very mild case, actually, with beautiful dentition. No crowding. I think Dr. Madsen could speak about this case. And this was a case that I felt we could restore it because it was very mild, although it affected all the 4 molars. So we don't know at this point, when I saw her, when would the other 3 molars break down? How severe would it be? And how much more intervention this child could take, because the dentist already had to bail out on the tooth 6. So, and although the other ones haven't broke down yet, they will. The question is when. So also, again, send for orthodontic consultation, and then Melanie can contribute.
Yeah, do you mind going to the pan for this case?
Yes.
So this is an interesting case with, a couple different options and different factors at play. So when you're looking at the pan, we can see, potentially mild crowding developing in the maxilla. So with the 3s, 4s, and 5s just looking a little tight together there. And then on the lower arch, kind of minimal to no crowding. Really long roots on those 6-year-old molars, developing 7s as well as developing wisdom teeth. I'll be touching a little bit on, timing perspective for these sorts of cases shortly, but, this is really one thing, as Nancy had said, where, we're potentially going to be restoring 4 teeth over the course of a lifetime. And that's very manageable depending on a child's behavior and attitudes towards dental treatment. On another hand, as far as timing of extractions, another option to consider would be to extract those all 4 first permanent molars and allow drift to occur to help with space closure. And for a situation like that, you would definitely be needing to do some orthodontic intervention later on to improve the alignment of the 5s and the 7s afterwards. But both would be valid options, restoring the teeth versus extracting. And it would be a good discussion to have with the parents and with the child, and to let them decide what's best for their family, their current financial position, and their long-term expectations.
Correct. This is when we see this child that had no experience in dentistry, very good, very cooperative, up until they started drilling that sensitive tooth. And now she wants nothing to do with the dentist. We've lost her. Yeah, now she's like, the thought of it, she's in the chair, she's crying. Is it going to hurt? Is it going to hurt? So parents are like, I said, yes, it does hurt. So we cannot go the same. We have to find an alternative way to do it. And parents ask you why. The cavity doesn't look so bad. And it's hard to explain. And it's hard to understand. I found this paper, I'll have the reference later, but we all know these molars tend to be more sensitive, but we needed evidence of that. So these researchers did, they extracted first molars with hypomineralization. They classified them, and they had surveyed the patient and see who had sensitivity, who hadn't, and then they did the histological preparations. So this is a normal molar. And this is towards the cusp of a molar that is healthy. So this is the appearance of the innervation. So that's what the coloring is there. So that's normal innervation in a healthy 6-year-old molar, or healthy 6. This is proof that is increased innervation and hypomineralized molars. So they will feel more pain. Now, the areas where they found the increased innervation or more nerve endings are the tip of the cusps, the middle, the center of the occlusal surface, and not as bad in buccal or lingual. So when you touch it, you know when they're gonna jump.
And is it harder to anesthetize them as well?
What was that?
Is it harder to anesthetize them?
It's very hard because there's a lot more nerve endings and they don't connect exactly the typical way. So there's a lot of ways the anesthesia gets, missed. It requires a lot of extra and probably intra-ligament and all these tricks that you can possibly use. And like I said, sometimes even under general anesthesia, when you're treating these children, you can see their pulse going up as well. So you feel them, yeah. And another important finding from this paper is the inflammatory infiltrate on those as well. So you can see a healthy molar versus you can see a hypomineralized molar. That the little blue or fluorescent specks are leukocyte infiltration, so inflammatory response, which is also responsible for pain. Do you have time for any other case? How are we doing for time, John?
Well, we're moving along. It's I have a hard stop at 5 o'clock. It's 4:10 now. So and Melanie,
okay,
yeah.
Okay. So I have another case. Healthy 7-year-old boy. Again, a good one, cooperative, pleasant, with very consistent, regular dental care. Parents they love going to the dentist. Their dentist is a family friend. It's just beautiful. They go every 6 months as your dream patient. Excellent oral hygiene, no crowding, no history of cavities. Goes for his regular 6-month checkup, and the dentist calls me, what is this? They're family friends. They've been coming forever, and what happened? He is scared because he has to face now his family friends. 6 months ago I told you he was perfect, and now I have to break this news to you. So everybody's freaking out. So they come to the office. He is in pain. The 236 hurts quite a bit. He has fabulous dentition, good oral hygiene, but in this case all his 4 molars are compromised and quite severely. His dentist had seen him 6 months ago for a regular checkup. The molars were brand new when he saw him, and he saw just that little whitish thing. He didn't think any of it. 6 months later, this is where we're at. Again, orthodontic consultation. This time the compromise is severe, and it's all 4 molars, and it's a young child. He's already in pain. Most likely we're into the pulp and at least one of them. So again, I do the orthodontic consultation, and at this time the orthodontist said, go ahead, take them out right away. She said the cases, they are just all so severely compromised, and if they broke down so quickly from the eruption to that visit, she didn't want any chances. She didn't want to cause any more discomfort in this child at that point, so we went ahead with the 4 extractions. So we brushed over this again, but just to summarize, the challenges and the restorative options are there. Make sure that you know and you realize it might be difficult to achieve full anesthesia. Make sure you can lose a good child to behavior and they will never forget that experience. That will be also always what they think about dentistry, that pain. What options do you have? General anesthesia. Are you going to do sedation, mild sedation, nitrous oxide, whatever your options are? And determine how much enamel you're going to remove, enamel and dentin. Remember that failure that I had. I thought I had removed enough, but maybe I didn't, or and select a restorative material. Definitely composite glass ionomer or stainless steel crown are your best, and amalgam maybe not the best at that point. This is one of the papers that I took for the pulpal status of the hypomineralized molars, and like I said, the conclusion is that there might be inflammatory changes already present within the pulpal tissue of these teeth. And yes, they tend to be more sensitive, and now we know why. There's a lot more nerve endings in this teeth. So this is where they took the histologic samples from the tip of the cusp, from the bottom of the occlusal surface, and the buccal. So we went back to my first case. How did I restore this case? Obviously proper, I did it under oral sedation, mild oral sedation. I achieved proper isolation. I removed compromised tissue, and I used a material that is called Activa. I don't know if you're all familiar with it now. It's one of the bioactive materials. Seems to be the research backing it up as especially good in these cases. And then restore with composite. Prognosis guarded. Parents know. He did not have compromise of any other molar, so we didn't consider extractions because it was localized to this one tooth. So extractions might have been a little too excessive.
Right.
And so like I said, we can do either complete removal of the compromised tissue or only remove the porous enamel. Who knows? Prognosis guarded. That was the final restoration. Parents know he might need a full PFM or something like that later on, but the tooth is asymptomatic and everything is keeping up. I think to kind of round it up, children with molar incisor, keep this in mind, children with molar incisor MIH receive way more dental intervention. It does not end at that feeling, sadly enough. And a Swedish study reported that children, or the 41 children they followed up that had hypomineralization, received 10 times more dental treatment associated to this teeth than controls. Yeah. So when we start at the age of 5 or age of 6 and 7, and we're thinking 10 more times, and how that's going to affect behavior, compliance, finances, and the rest, it's good to have maybe a more proactive approach. That's my take on it. We talked about materials, and going to materials, we all know enough about composites and glass ionomers and all that, and Activa seems to be the way to go. So forget about releasing fluoride. Fluoride seems to be now old news. Now we're talking about releasing calcium directly into the pores, to the structure, and with success. When I've used it as a base or as a, I call it temporary restoration material, although is marketed as a composite, but it releases calcium and into the porous enamels. So great success. I haven't had any post-op sensitivity, and the jury is out as to what the prognosis will be for those in the future.
Right. Yeah.
Nancy, could you comment on why amalgam is a poor restorative material for these teeth?
For these teeth, I love amalgam. I gotta say, I'm a big fan of amalgam. That's my main restorative material for primary teeth. But if because these defects are so irregular, and you have to sacrifice enough to the structure already as it is to get somewhere. We want a material that can give something back, not just to fill the hole, but also bring the walls together and release some type of remineralizing substance. Like, that's why Activa is now my material of choice. Mm-hmm. And the bonding around the walls to bring the defect together and hold it for, as long as possible. That's my choice. My take on it. I think amalgam will not hold, and because of what they say, the amalgam won't hold this as well, but also because the borders of the edges of the restoration might be affected also microscopically. You will have more breakdown showing up around the amalgam.
Right.
Also, full coverage is ideal in some cases. It definitely will hold the tooth together, or whatever remaining structure. It will be less likely to have tooth sensitivity. You better to have interproximal contacts. It's not as technique sensitive, especially if you have to battle some behavior. Relatively less costly now. But in the future, you have to tell these parents, listen, this is a temporary restoration. Then you will need to invest much more in the tooth, and you go back to your general dentist or prosthodontist or whoever else when the time comes. Now, the time used to be after the growth was finished, but new papers that I was reading, actually, there's a study being followed up on children who had full coverage with permanent cast restorations at the age of 8. And I think they're being followed up now for the 4th year, and everything is well, and nothing terrible has happened. The restorations are there, and they were able to successfully restore this teeth this early in life, which, I mean, good for them. And now I'll get Melanie with the extraction and orthodontic management. I think the take-home message from me is also consultation. Involve all the experts that you need. Make sure the parent gets the message from different angles. Is yes, we're going to fix it now, we're going to extract it later, or we're going to extract it later, we're going to do braces, or we're going to temporarily fix it, or we're going to fix it what we call permanently, but we don't know what the prognosis is. The more we tell these parents and these children, the more they can make an informed decision that doesn't come back to you as like, you fixed that tooth, you charged me for that, and now we have to do it again. What's going on? And now she hates the dentist, and now she's in pain, and all these things that come back to us and kind of bite us.
Yeah. So a lot of very delicate management.
Talking about some of the considerations from an orthodontic perspective when managing these cases, obviously, as you'll see as we go through, timing can be critical. So timing of a referral is very important. But also every case is different. So, as much as we like to think that there are rules and regulations, everything needs to be approached on a case-by-case individual basis.
Thank you for that. So let's roll.
Great. So when it comes to the orthodontic management of these cases, there's some issues behind it. So as Nancy had touched upon, what is the long-term prognosis of these teeth? Are they going to, or will we get 6 years out of them? Can we get a lifetime out of them? And then as part of that, what is the burden of treatment going to be? So is it going to be restorations? Are we going to need endodontic therapy? Are we looking at crowns, extractions, implants, orthodontics? What's the quality of the enamel involved? So from an orthodontic perspective, I'm thinking, can I bond to that tooth?
Yes.
Can I bond a bracket? Is the morphology such that, can I even fit a band upon that tooth? And is it, restored in a way that I'm going to be bonding to restorative materials? Often too, when we're seeing hypomineralization of molars, it's not uncommon for us to have other associated dental anomalies. So whether it is tooth agenesis, small upper laterals, the protrusion of primary molars, or palatal displacement of upper canines. Often when you go to take a pan on these patients, there's more than initially meets the eye. And of course, there are some significant challenges involved from an orthodontic perspective with the treatment planning and space closure. So we're often looking at prolonged treatment times or possibly more complicated treatment mechanics when we're extracting first permanent molars versus premolars or non-extraction treatment. So there are a few reasons why we may want to extract first molars. So when we have extensive caries or very large restorations, as Nancy showed, cases of irreversible pulpitis or apical pathology, very severe hypoplasia. And then from an orthodontic perspective, if we have posterior crowding, especially in the presence of developing third molars, if we have somebody who's a vertical or dolichocephalic facial type, or when we see an anterior open bite malocclusion. As far as considerations as part of the treatment planning, of course, how many molars are affected? We'll probably treat one affected molar differently than we would treat all 4 affected molars. What is the dental age of the patient? So how developed is the dentition? What sort of things would we be looking at if we wanted to do treatment now versus treatment later? We also take our orthodontic diagnosis into consideration. So the amount of crowding, the occlusal relationship, the skeletal relationship, those would all lead to very different orthodontic treatment plans from when in the absence of compromised first molars. And so, of course, when we do have compromised first molars, we're treating them all differently as well, not with just one cookie cutter approach. As I mentioned, when we have one dental anomaly, we will often have others. So it's important to assess the dentition as a whole. So are we seeing other missing teeth that may preclude us from wanting to extract? Or some teeth looking compromised, impacted, etc. And then, of course, if we have developing third molars, we might be more inclined to extract first molars if we know that the patient could potentially still end up with 2 sets of molars at the end of the day. So questions to consider when you're treatment planning these cases. So is the tooth worth saving? So are my efforts to save the tooth going to pay off? Or should we look at doing something else? If we're looking at extracting, we want to extract now. We want to temporarily restore it and save it for a later date. And this, of course, is a question that should be discussed between the restorative dentist and the orthodontist. And then if one first permanent molar does require extraction, say for severe compromise, should we look at taking others out as well? And this is what we call the concept of balancing versus compensating extractions. So a compensating extraction is when we look at extracting the opposing tooth, and this is done to prevent supereruption. So this is, of course, more of a concern when we're extracting mandibular first permanent molars, as we've all seen how quickly and how significantly maxillary first molars can supererupt, and the difficulties and challenges that can go along with that. Balancing extractions would be when we're extracting a contralateral tooth for the purpose of maintaining midline coordination. So this is less critical from a timing standpoint, and neither of these extractions are always necessary. Often this is something we'd be looking at doing in conjunction with comprehensive orthodontics. And from a balancing extraction point of view, it doesn't necessarily have to be a first permanent molar that we're looking at taking out. It could be a premolar on the opposing side. And of course, as I'd mentioned, different malocclusions will lend to different types of treatment. So for a class 1 scenario, or like one of the cases that Nancy had showed, we may be looking to do some sort of balancing extractions to maintain symmetry. Or if we have a spaced dentition where extraction space closure would be difficult, we may try as best we can to avoid having any molars extracted on these cases. For a class 2 division 1 type malocclusion, this is where we may consider temporarily restoring maxillary teeth until the second molars have erupted. The reason being is that those teeth are helpful for anchorage, and when we're looking to do extractions on the maxillary arch to reduce overjet, then we need to be able to bond to something distal to the extraction site to retract the anterior dentition and eliminate the overjet. So that's an example in this case that I'm showing here. So you can see that the hypoplasia of the molars is relatively mild, and more so on the right side than the left. So in this case, we may be able to maintain these teeth for a lifetime for this patient, but definitely we wouldn't be in any rush to extract them. because if once they come out, the 7s are going to slide right into that spot. And then we would be looking at much more difficult orthodontic treatment to try and retract the whole dentition en masse. Class 2 Division 2s are a little bit trickier of a scenario. So if we have compromised mandibular molars, we will try to preserve these if at all possible, just because when we're dealing with a case where we already have a deep overbite, the further back you extract, the deeper your overbite is going to get. And so this can lead to difficult orthodontic treatment when it comes to leveling the dentition. You'll be struggling to correct the overbite, and then also struggling to close space in these cases too. From a profile perspective, sometimes lower arch extractions can have a negative impact on somebody who has a retrusive profile as well. And then when it comes to class 3 malocclusions, there's, they're all treated on such an individual basis, depending on the jaw deficiency or jaw excess and amount of crowding, that I don't even want to speculate on what an ideal option would be for those, but definitely a referral and some multidisciplinary treatment is the best option there. When it comes to timing of extractions, so if we are aiming for full space closure, when we're looking at the mandibular first permanent molars, this is a situation where timing is a little bit more critical. So we're usually looking between the ages of 8 and 9, and the landmarks would be before the eruption of the second molars, when the developing second molar has a bifurcation visible. So if the extraction occurs too early, one thing that we can see is the second premolars losing their path of eruption, and a more higher tendency for them to become impacted. So basically, if you're providing a path of least resistance for that lower 5 to erupt into by extracting the tooth behind it, if it's not far enough in its development. So of course there are situations where you may have to extract lower molars at age 6 or age 7. But if so, careful monitoring is going to be required of the development of the lower 5s. And if you see them starting to go off course, consider early extraction of the lower E's to prevent those impactions from occurring.
Right.
When timing is correct, you can expect to get some distal drifting of the second premolars, as well as mesial migration of the second molars to achieve contact between tooth number 5 and tooth number 7. But if we're looking for perfection, then usually you're going to have to do some orthodontic treatment to upright those 7s. When we are looking at extracting lower first molars in the presence of developing wisdom teeth, you can expect a 90% chance of the wisdom teeth having space and being able to be functional teeth. This is compared to 55% success when premolars are extracted. And of course, if, as I mentioned, if the maxillary molars are not also planned for extraction, you should consider doing some sort of management of those teeth to prevent their supereruption, whether it's some type of bonded or removable holding arch, but that on its own should be adequate to prevent those teeth from over-erupting. Or in a pinch, even a bonded wire across from the E to the 6 or 5 to the 6, just to hold everything in place, can go a long way to preventing excess treatment to improve the position of super-erupted teeth. When it comes to maxillary molars, their development is working a little bit more in our favor towards space closure. So you do have a larger window of time to extract those teeth to achieve contact between the 5s and the 7s. And often that can be done even without having to require orthodontic intervention later on. The window of opportunity could be as long as from about 8 years old, even until the initial eruption of the second molars. But ideal timing has been identified as when the second molar is unerupted and is sitting apical to the CEJ of the first molar. So when extraction happens then, you have the highest chance of getting complete space closure between the 5 and the 7. Once again, extracting too early, so prior to age 8, can lead to unfavorable eruption of the second premolars, drifting into a distal position. And it's almost like they jump over the roots of the E's and try to erupt behind them. One advantage of these types of extractions is that rarely would we have to worry about super eruption of the lower first permanent molars. Even if they're left unopposed for years, rarely will we see much change in the occlusal plane of the lower arch. And once again, most of the time, if you have developing third molars, you can expect them to erupt into a functional position if we're missing first molars. So when it comes to, we've talked a lot about managing these conditions in children, but what about adults with compromised first molars? So because the first molar is the first tooth to erupt into the mouth, and it's at the time when maybe hygiene isn't the best, maybe we have compromises in enamel, but over 50% of adults will have some sort of restorations on their first permanent molars. That could be anywhere from occlusal fillings to crowns, root canals, etc. So some of these can be fairly heavily restored or somewhat compromised teeth. And as we can see in this image here, extraction and drift of these teeth in adults can result in favorable or unfavorable occlusal changes. So what we're seeing here is the anterior dentition staying locked into a nice class 1 position, and then that 7 just tilting forward unfavorably. So this area right here is prone to food trapping, vertical bone defects, etc. So this is a situation that ideally we do like to try to avoid. Luckily, from an orthodontic perspective, temporary anchorage devices have made these cases a lot more easy to treat orthodontically. But patients can expect to have at least a 6 to 9 month increase in their treatment time when they are dealing with molar extraction sites versus premolar or non-extraction treatment. And I have a case to show you here where we were dealing with a compromise of a first permanent molar. So adult patient with a asymmetric bite, so class 2 on the right side, class 1 on the left, and a significant maxillary midline shift to the right side, yes, and significant crowding upper and lower. And tooth number 26 has a heavy restoration on it. So if we look at the pan here, we can see that tooth, relatively unrestored dentition elsewhere, but tooth number 26 has a huge amalgam filling, and it's hard to see on the pan, but there was also an incomplete fill and a root canal in that tooth. So it's hard to justify when we're looking at doing extraction treatment to leave that tooth behind and look at taking out a healthy premolar instead. So in this situation, we extracted 4 first premolars and then the maxillary left first molar. This is after we had finished tooth alignment and we were ready to start space closure. I placed a temporary anchorage device on the left side, just mesial to the extraction site, and used direct anchorage to the temporary anchorage device to help slide the anterior dentition over to the left to correct the midline, achieve class 1 canine, and work on space closure. So at the end of treatment, we can see that we've achieved midline symmetry. Some irregularities in the occlusion just by having premolar and molar opposing, but we've saved this patient from having to have a crown placed on that 2-6 and left with a much healthier dentition than she started with. And from the pan, you can see reasonable root approximation despite closing such a large space on an adult. And the interesting thing to note here is with the removal of the premolars on the bottom, the wisdom teeth, which were previously soft tissue impacted, have migrated forwards even without being bracketed. So she may actually be able to keep those teeth. So I would have to say the take-home message from my part of the presentation is that if you have any questions or whenever you're in doubt about the management of these types of cases, whether it's a child with hypomineralized molars or an adult with some sort of orthodontic need and some molar compromise, don't be afraid to consult with an orthodontist. Ideally for children, we would be looking for a consultation by 8 years of age, just because the earlier we start the discussion, the more options that we have available. And, the sooner that parents hear that their child is going to have some sort of treatment need, the more time that they have to prepare for it and make up their mind on what exactly it is that they want to do.
Right.
And then those are just some references that I've included for my information today.
So thank you both very much for very comprehensive presentations and clear take-home messages. Every case is different. Timing is important. It's very, very delicate. You can lose a patient if we do too much dentistry too early and just things don't go right. And we got to get multidisciplinary involvement. Does that sound like the wrap-up? Would you agree with that, or would you have other points that you'd bring in?
Absolutely.
Great.
Yeah. Well, I'd like to thank you both for all the presentation effort you put in today. Certainly we got a very good tour of the waterfront from two very important perspectives. I want to thank viewers who participated, and of course we'll be presenting a recording of this session with a printed summary on Oasis as soon as possible. And we look forward to viewers' feedback and suggestions for other sessions at other times. And Nancy and Melanie, I hope you'll have enjoyed this enough to want to come back again another time.
Anytime.
Thank you so much, John, for facilitating this too. It's been a great experience for us to get to team up a little bit more and continue the discussion on this topic.
Well, what we hope to do here with Oasis and using the Zoom platform is to bust geography. You're both in Vancouver in your own offices, and I'm here in Ottawa. We're talking to each other live, and there's people all around the country and beyond. And this means geography is not so important anymore for exchanging ideas. So,
Absolutely. Thank you.